Yeah, this is our first class in a series. We're going to be teaching everybody outreach skills in the beginning, and then we're going to be proceeding through new topics every week. This week, the modules are going to be on diabetes and stages of change, which is kind of like a method that you use to help people change their behavior, but in a um, evidence-based way that's non-confrontational. So, what is Valiant Foundation? So we are a student-led organization focused on public health and research. We provide a lot of social support to the community by giving out like aid packages, medical supplies, and checkups. We mostly work in San Francisco, but we are doing research to impact the rest of the communities elsewhere. I am Jeannie. I started Valiant Foundation, and I'm the president of the board of directors. I'm also the director of research. I'm an EMT. I've done the suicide hotline counselor thing at 988 for a while. I What kind of set me up to start this business is I started a equestrian business when I was younger, so I kind of understood how to run a large group of people. Then I sold that because it took up too much time. Then I started Valiant Foundation. I'm a senior at SF State. I'm getting ready to apply to MD, PhD programs. So, homelessness in San Francisco. This is kind of a big issue. Back in 2024, we found that over 8,000 people in San Francisco were homeless, and almost 3,000 of those people weren't residing in shelters. So, nearly 3,000 people are just out on the streets. Um, and It's been decreasing, which is really great, but we still have a lot of work to do. So we do a lot of outreach. The first few minutes of our lecture is I'm just going to review our outreach skills for all of you great people that go out into the field to collect data on our research missions or go out just to provide resources and counseling. So I want to reinforce some of these soft skills. So these are really great for when you're communicating with unhoused people who are struggling with kind of like that might have a kind of a calloused facade going on. They might not want to um, be as excited to talk to you. So if like a unhoused person really wants to talk about something like drugs or not like doing drugs in front of you, talking about addiction or really bad things that they're trying to like they asking you for drugs or asking you for alcohol, things like that. We want to redirect them. So talk about like the feelings behind that. Like, I'm really sorry that you're going through this drug abuse and offering resources to help with drug abuse. Active listening. So a lot of people think active listening is just sitting there and um, hearing what the person is saying, but we want to add to that. We'll learn about active listening as later on, but we want to add like minimal encouragers, which is a technical term for things like yeah, just so the person understands that we're paying attention. Even asking little questions or prompts like "go on" or "wow, that's interesting" or "tell me more." It's a really good way to make sure people know that you're listening to them, and that's kind of how we establish trust. Being culturally sensitive, being mindful about um, different like races, religions, creeds, and documentation. So when we reach out to a homeless, unhoused person, we always have to document that in a few different ways. We have to use our drop pin app, so that way we mark every time we've spoken to somebody. That's important for one of our research teams. We're collecting data that we're trying to send to SF County about where homeless people are in San Francisco, and you'll see a little slide on that later. So, a little disclaimer before we talk about the medical skills today. We're not allowed to provide medical advice or treatment. We're just volunteers, but we are protected under the Good Samaritan law, which means if somebody's having an emergency, you're allowed to give them Narcan, you're allowed to do CPR, you can call 911, you can use your suicide counseling skills to help them. Um, we just can't say, like, if we take somebody's vital signs and we ask them these questions and we give them like referrals to doctor's offices, we want to steer clear of saying like, oh, your blood pressure is really high. I think you have hypertension. Oh, your blood sugar is really high. I think you have diabetes. So we don't want to diagnose somebody, but we want to say, hey, I have a resource for you. BSI, so body substance isolation and PPE. When we go into homeless encampments and we like they're doing drugs or something's, it's just a little bit grimy, we really want to wear masks. That's very important. Right now, I'm doing a lot of research into the homeless population, and one of my studies is type 1 diabetes. And in that, we learned a lot about viruses that cause type 1 diabetes, but also how just prevalent like viruses like tuberculosis and enterovirus are in these populations. So we really want to wear a mask if we're going to be in close contact with somebody, like when we take their vitals or do a checkup. In addition, every time you touch somebody, you have to wear gloves. This is for a couple of reasons. It's to protect you, but it's also to protect everybody else. You're going to be handling a lot of unhoused people when you take their blood pressure, their heart rate. So we really want to wear gloves to protect them. And then we always have to clean off our equipment once we use it. Scene safety. I really like these AI images. They all their shirts say Valiant Foundation. Um, but it's very important to be aware of your scene. Like as an EMT, I've had to walk into some very unsafe situations and have to really, check my back. I know a lot of you guys are EMTs or medical assistants or are in nursing school or already finished our bachelor's and are working full time in healthcare. So you guys understand that. But for any new volunteers, it's really, really important. Like you have to be aware of the ground. Like, are there needles? Are there sharp objects? You have to be aware of like your head. Like, is somebody angry or gonna hurt you? These are very, very unlikely, especially considering the extra protocols Valiant Foundation takes. We like to we don't even wear the shirts anymore. We don't wear the uniform shirts because it makes us feel like more approachable. Like we're not some agency, we're not police officers, we're not trying to hurt them. We're just a peer talking to them. So it's very unlikely that people are going to be angry at us. In fact, we've never had a homeless person be upset that we've talked to them before. The only time, only one time we had a bad situation, that was just some random guy was following me and one of my interns because they're really upset that we were giving homeless people food. So apparently the bystanders are more dangerous than unhoused people. So I want to talk a little bit about kind of like the health aspect. So I'm just going to go briefly over the most basic things you need to know to be equipped to handle an emergency. So I always like, they always say ABCs, airway, breathing, circulation. Those are the most important things to sustain life. So airway, we're checking like if, let's say we come across an unconscious person who is like overdosed or he got hurt somehow, he got hit in the head. One time we had some people go out and somebody got hit by a train. And the outreach people had to deal with that. So this is kind of like why we're teaching you this, because we want you to understand airway, breathing, circulation when you encounter these emergencies, because you really might it's like, is there airway patent? That's the word for being able to breathe in and out without having any obstructions. So, like, is there vomit in the airway? If there is, you want to turn them on their side. And if they're unconscious, you still want to turn them on their side because they can aspirate on their vomit so they can choke on it. Stridor, so that's a sound that you can audibly hear with even without a stethoscope that comes from the epiglottis. It kind of gets trapped. It kind of like constricts and it causes like a squeaking sound. So you can hear it audibly in severe cases, like somebody gets airway burns, like they inhale a lot of smoke, or if somebody is choking on an apple, or if somebody has anaphylaxis, they got stung by a bee, you might hear this squeak, and that's really, really bad. You always, you quickly call 911 if there's anything wrong with the ABCs. It's really bad to have airway obstructions because you only have a few minutes without oxygen before brain death. And then impaling objects, this is less common, but it still happens. You never remove an impaling object unless it is interfering with your ABCs. So if somebody can't breathe because something is impaling them, then you can take it out. But that is the only time you can remove an object unless it's interfering with CPR. Breathing. So is the breathing, we want their breaths should be between, around 12 and 20 breaths per minute. And It's pretty important. We're going to be when you go out into the field, you'll learn how to do that, listen to the breaths and make sure they're the right rate. But are they faster than 20 breaths per minute? Like are they 30, 40 breaths per minute? Are they shallow? Like are they overdosing? If they have shallow respirations, that's pretty bad. We need to call 911 immediately. Give them Narcan if you think it's an overdose, like pinpoint pupils, decreased respiration, loss of consciousness. And a pretty good test if somebody's breathing is, can they hold a conversation with you? If yes, they're breathing and airway are fine, very likely, but if they can't speak in full sentences, you know there's something up with either their airway or breathing. Circulation. So the circulation can be assessed in different ways. Like one example is looking around them. Is there a pool of blood? That means their circulation is being heavily impacted by extenuating circumstances. If they're bleeding a lot, you should apply pressure to the blood after putting on gloves first, because a high proportion of unhoused people have bloodborne illnesses. So we really want to wear appropriate PPE, even if it means saving somebody's life. We put on the PPE first, and then call 911 after applying pressure. Um, Skin signs. So is the skin pink, warm, and dry, which indicates good perfusion, or cool, pale, and diaphoretic. And diaphoretic means it just means sweaty. And then cyanosis. And sorry for kind of talking about this for all of you many medical professionals already in the meeting today. And then cyanosis, that's like bluing around the lips, cyan, and fingers. And then one other thing about this, this is a really good thing to check is like you can press on your finger or their finger and release, and the blood should return in less than 3 seconds. That's called capillary refill. The cap refill time should be under 3 seconds. And if it's takes longer than that, that signals there's probably something really wrong with this patient. Not patient, this client. Another thing we want to be aware of is aggressive behavior. I've never seen this happen before, but we should be aware of it. Kind of like sometimes if you give somebody Narcan, they might wake up and be very aggressive. So we want to, kind of be ready for any kind of circumstance. So warning signs, maybe people are wrinkling their face, fidgeting, moving into your personal space. They might be very tensed up and angry. And using body language, like if you notice that, you should just exit the situation. We don't need to risk ourselves. If they don't want us there, we're not going to be there. And ways to kind of prevent that kind of like, prevent people from being upset is use half smile, willing hands. This is something you'll learn if you continue to work at our program at the hotline. You want to smile and open up your hands. So willing hands, that just means opening. When we open our hands, that signals to people like we don't have anything in them. Even if people aren't consciously thinking that, it's still like a subconscious sign, like this person's smiling, their hands are open, they're not a threat. Standing at an angle too also is another great way to kind of be more like passive and friendly. If you stand directly at someone, it's kind of more serious. So standing at an angle is another proven way to calm situations down. And then always have an escape route. Don't trap yourself between a wall, and a wall and somebody who could be upset with you. We don't know. Additional resources. So you guys will all have these when you go out on fields, but always remember, call 911 for emergencies. You can refer them to the 988 hotline. We're going to be changing that soon. We'll refer them to the hotline if they're suicidal, but we're also going to be referring them to our own hotline. Valiant Foundation established a program that we accept calls, and we'll actually reach out to them and call the unhoused people if they're having a hard time. Um, and then the mobile crisis team, you should dial 911 and ask for street crisis. That's important because sometimes the police aren't very good at handling these mental health problems. So street crisis, that's literally a therapist and a social worker or an EMT that come out and talk to these people and calm them down without having law enforcement involved. So that'll be reinforced to you guys when you come in on the outreach missions, but just remember street crisis when you have to do that. And we're giving you animal control's number because sometimes, like I've had patients out in the field when I'm working say they don't want to go with you on the ambulance, or they don't want to go to the hospital, or they can't do this or that because they have a pet. And that's really, really scary for them. Like they might love their dog. Lots of unhoused people have pets. And if you go to the hospital, you can't bring your dog with you. So you can let them know that animal control in San Francisco does come out and take your pet and holds on to it if you're in the hospital. Vital signs. So your blood pressure should be above 90 systolic and above 60 diastolic, and then below 120 systolic and below 80 diastolic. And I would say this is the normal range quote, but in real life, this is not actually how your blood sugar is, or your blood pressure is. A lot of people have very high blood pressures, and it's not good for them, but it's not an emergency. Once your blood pressure gets to about 100, once your blood pressure gets to exactly 180 uh, systolic, then that is considered a hypertensive crisis and it puts you at significant risk for stroke. Um, and strokes have a very high fatality rate. If we see somebody with a blood pressure that high, we really, really want to encourage them to go to the hospital. We never call 911 against somebody as well if they're fine, if they're able to decline services and say no. If they're A and O4, they can answer who they are, where they are, what time it is, what's going on. But other than that, we really want to encourage them to go to the hospital. But if they can't answer those questions, they don't know who they are or where they are, what time it is, what's happening, then we would call 911 regardless of what they say, because at that point, they don't have the term capacity. They can't provide consent or withdraw consent. So we need to get them help. And then low range, I know it says the normal blood pressure is below 90 systolic, but I've been an EMT for over 3 years, and I've actually seen a lot of people, especially people who are unhealthy, maybe overweight, older, have health conditions, and their blood pressure drops below 100 and 100 systolic. And that actually, some people can have syncopal episodes, they can faint because of it. They can have a lot of hypotensive symptoms, even below 100 systolic, even though that's technically normal. It's not normal for them. Oxygen range, think A plus. It should be above 95% on O2 saturation. And the heartbeat should be 60 to 100. Much higher than that is a problem, especially if they're at rest. If they exercised a bit, it's usually not, it's normal for it to be elevated if they're exercising. And then lungs, they should be clear bilaterally. So when you listen to the lungs, you listen into 6 places on the front, 6 places on the back, and we'll teach you how to do that. They should be clear bilaterally, no wheezing, crackles, or rhonchi. Um, Crackles is another term for rails, so it's like a sound of like slush, like gunk in the lungs. Rhonchi is gunk in the lungs, and then rails, that's kind of like rocks scraping together. And those can be different things. Like rhonchi is a sign of like pneumonia. Rocks scraping together, that can be, a sign of a million different things. So you want to watch out for those when you guys take their lung sounds, and then always never tell somebody they have asthma or you have pneumonia. Say like, hey, I'm not a medical, I'm not a EMT right now, or you can like even if you are an EMT, you shouldn't say like I'm an EMT. You should say, hey, I think you should go get seen by a doctor. You can see a free doctor here, and then list why you think they should see a doctor and come to a decision with them. So shock. Go back a slide. So I'm going to quickly tell you what shock is. So your blood pressure drops really low. Your heart rate goes pretty high. Typically, your blood pressure is below 100 systolic, and your heart rate is quite a bit above 100 beats per minute. And people can have something called shock. Shock is the inability for your organs, like internal organs, to get enough perfusion. And this is the number one pre-hospital killer in all humans. And it's if your organs can't get enough blood for whatever reason, like hypovolemic shock, you're bleeding too much, distributive shock, you have like an allergic reaction, and all of your blood vessels are opening because of your nervous system is all freaking out. Cardiogenic shock, you may have had a tension pneumothorax or something like that, and then your lung collapses onto your heart and stops your heart from beating. Those things can all, or yeah, or you can have anaphylactic shock, which is a type of distributive shock. I think I already mentioned that. But Shock kills, low blood pressure, high heart rate. You position for shock in the field when you call 911. So, does anybody know which position we want to put them in of these six over here?
Um, it's the left lateral or the right lateral,
Yeah,
right?
yeah, yeah. Left lateral or right lateral. So it's really good to put them on the sides. I always prefer to put a patient on their side rather than on their back, supine, because when they're in lateral recumbent, they can vomit and it will come out of their mouth most of the time. But if they're supine, the vomit will go back into their airway and cause an obstruction, so that can kill. So we don't want that to happen. Even if they're very conscious, then it's fine to keep them supine, but otherwise it's good to be on the side. So position, lateral recumbent, oxygen. So we on the ambulance, I can give patients oxygen, but here we can't give them oxygen because we don't carry it. It's dangerous. So another way we can ensure oxygenation is through like calming their anxiety, like breathing. Say like breathe in for 4, hold for 4, breathe out for 4. That's a good way because you're a lot of times in shock, or like cardiac arrest, for example, or I don't know, STEMI. People will have like the cells in their heart are starting to die because they're not getting enough like oxygen. So if somebody's having a myocardial infarction, we want to coach them through breathing to kind of oxygenate their cells a little bit more. Warmth, so shock, it dilates all your blood vessels. Excuse me. So we want to warm them up to kind of help with the blood vessels, improve circulation, and transport, get an ambulance as quickly as you can. Here's some analytics from December. Uh, as you can see, about 30% of people wanted their vitals taken. Yeah, about 30% of people wanted their vitals taken, and about half wanted supplies. And another, like, I don't know, quarter of people didn't want anything, or miscellaneous, like wanted directions, or just, oh, I think miscellaneous, actually, these people just wanted like counseling. So we just talked to them a lot. So as you can see, you're not going to always be taking vitals, but you should be prepared to do it. PSS 10, and I quickly go over this. This is for the research. Just ask them these questions on a scale from 1 to 4, and it will be in like a Google Sheets format. So you'll go out with a little like sheet thing and you can write down your answers. Sample history, I'm going to skip this. Not pertinent today. So on to today's topics, diabetes and homelessness, and the transtheoretical model of change. So I'm actually doing research with diabetes and homelessness, where my team and I are exploring how homelessness impacts the management of T1D. Um, we found some interesting stuff. So, what is diabetes? There's different types, like type 1 diabetes, that's your beta cells. These are cells, in your body that kind of like these cells help produce insulin. So when the beta cells get stressed from a chemokine release, these are kind of your immune cells. It destroys the cells, and then your cells are no longer able to produce insulin. And this is for type 1 diabetes. Type 1 is different than type 2. Type 2 is kind of like if you, a lot of times it's caused by obesity, or that can be a predictive factor, obesity and family history. It overwhelms the cells that produce, that accept the insulin. Insulin is like a key. It opens up the cell to allow sugar to flow into the cell. And it causes like dysfunction. So type 2 diabetes is you're not able to get sugar into your cells because whereas type 1, you're not producing any insulin. And it's a lot more complicated than that, but I don't have the time to explain it in depth. So, what is A1C? I'm sure a lot of you have heard of this before, so I'm going to talk about it a little bit more in depth. Um, so the A1C, that's a weighted average of your, excuse me, that's a weighted average of your sugar over a period of time. Usually it's about 8 to 12 weeks. That's roughly how long um, the glucosylated hemoglobin, like the cells, your blood cells, is last. When they start to die, you're kind of losing those. So it's a weighted average, which slightly skews more towards the last few weeks. Newer red red blood cells contribute less to this average because they've had less time to accumulate glucose, whereas older ones also contribute less because they're dying off. Um, yeah, so this little chart here, it talks about your A1C. We let's see, I'm trying to read it. So yeah, an A1C of about 7, that's your average would be 154. Your sugar should be between 80 and 120, but with people with diabetes, the target range is usually a little bit higher than that. Your renal threshold, that's a term for when you're about how much glucose that can circulate through your blood that your kidneys can handle is about 180. So anything above that, it stresses out your kidneys, and a lot of sugar can go into your urine. So how is A1C tested for? So hemoglobin A1C is tested using high performance liquid chromatography. For all of you people that have already taken OChem or are taking it now, we get to learn about a lot of chromatography in that class. So we do immunoassays and enzymatic assays to see how much of the glycated hemoglobin is in the N-terminus. It's a beta chain. And then what is the beta chain, you ask? Down here, I don't know if you guys can see my cursor, but this molecule with like the three little molecules in the bottom right, we have hemoglobin and glucose. As you can see, the two H's, the hydrogens, and the O, the oxygen, they're hydrogen bonded to each other. The hemoglobin has the amino group, and the the alkene oxygen right. Oops, there we go. The oxygen bond forms a hydrogen bond to the hemoglobin, and then you add water, and it forms like the it makes an alkene bond with the nitrogen to the ox or to the carbon, and that's called a shift base. It's kind of a transition state that isn't really calculated when we find our A1C, and then it rearranges. So we're changing the bonds from one of the carbons. We're protonating the nitrogen. So that turns into the atomori rearrangement, which is your HbA1c. And the HbA1c, when you're measuring that, that's literally this molecule on the far right, the atomori product. So you can kind of compare the product on the right from the product on the left for you guys that have done years of chemistry, like I have. I hate to say that I've done years of chemistry. It's a lot. So what is DKA and hypoglycemia? Signs and symptoms of DKA are like confusion, vomiting, exhaustion, flushed skin, nausea, polydipsia, so excessive thirst, polyuria, excess urination. They might have a fruity odor of their breath. This is the ketones. And in a minute, I'm going to show you guys the ketones because I know a lot of you are really interested in this stuff. And then hypoglycemia is very similar. They can have similar presentations, but they are different. And always check their blood sugar. But you want to think about um, the like people with hypoglycemia tend to have more diaphoretic kind of presentation, whereas people with hyperglycemia tend to have more sweaty, um, hot skin and fruity odor. And then hunger, so polyphagia, they're tired. We see a lot more hypoglycemia than hyperglycemia, and hypoglycemia is a worse emergency. So, a lot of you asked me to draw the diagram. I'm sorry for all of you who haven't done years of chemistry, but I was going to kind of explain it a little bit here because I think most of us are wanted to talk about the kind of like the process and how your hemoglobin dissociates. One second. Okay. So, two. So I was kind of going to outline the process of DKA. I really wanted to talk about this too because most of the people here are, I think, working on the diabetes study. I promised a lot of you that I'd talk about it. So, insulin deficiency. So, you guys like my spelling? Pretty great. Leads to lipolysis, so the burning of fat. The burning of fat leads, the lipolysis uses the two fatty acids in the liver. So fatty acid. Um, sorry. So the fatty acids in the liver, you have acetoacetic acid. Thank you for all of you who are on the diabetes study and willing to learn all of this. Um, a lot of you are in that study. So we have this acid here is called acetoacetic acid. We can see the carboxylic group on the left right here. This is kind of what turns into the ketone when people have ketones in diabetes. And then on this side, we have beta hydroxybutyric acid. So it's similar, but just a smidge different. Instead of a second double bond oxygen, we have a alcohol group. So how does this work? When people get ketones and diabetic ketoacidosis, these hydrogens deprotonate. So the extra bond is going to go there. Um, on, and then this thing is deprotonate. Um, and then they just turn into ketones. So these negative oxygen molecules on the sides kind of make the blood more acidic. And then the treatment, or then that causes oops, DKA. And then, you treat that with 0.1 units of insulin per kilogram of body weight. Thank you all for who's not on the diabetes study who did not ask for this for paying attention. And then you also, for elevated blood pHs, you add sodium bicarbonate. Whatever. So, yeah, so this is kind of the process. You don't have enough insulin, your fatty acids break down, they dissociate, and then you have to bring it turns into DKA. So are you guys able to see the screen, the presentation again?
Yes, we are.
Yes.
Great. So you're welcome for all the people who have done years of chemistry and or are working on the diabetes study, and I'm sorry for anybody who has not done those things. um, Research insights that we found from our study. It's a systematic review of type 1 diabetes management among homeless people. We found that 20% of low-income type 1 diabetics ration insulin, and over a third ration diabetic supplies like glucose test strips. Enterovirus runs rampant in homeless encampments or encampments and shelters, and it's also linked to type 1 diabetes. It's really hard to kind of quantify just how many people, unhoused people have type 1 or type 2 for that matter. We've looked at a lot of large high quality studies, and our approximation is about 90% of homeless people have type 2, whereas only around 2% have type 1. But that's weird because around 10% of diabetics in the real world, like overall, have type 1. So we're wondering where all of these people are going. We're a little bit concerned in our study. It might be like maybe these people just are dying from DKA or dying from hypoglycemia or other cardiovascular events like stroke, peripheral artery disease, heart attacks, and so on. So that's another reason why this research is so important. So RR, that just, that's it's kind of like relative risk. So like how likely you are, and like you're 1.78 times more likely to have heart failure if you're homeless and you're diabetic than if you're just diabetic and not homeless. You're 1.441 times more likely to have a stroke, 9.2, more likely to have peripheral artery disease. Diabetic emergencies are also much greater. Your 1.88 times, your length of hospital stay is about 1.88 times greater if you're homeless versus non-homeless. And that's hypothesized by our team. We think it's that way because they don't really have places to go after the hospital. It's out to the street and makes a logistical challenge. About half of homeless veterans with diabetes have both a psychological disorder or substance abuse issue. And studies have shown that drug abuse correlates with worse diabetic outcomes, particularly like A1C levels and hypoglycemia. And then homeless adults are less likely to see a doctor and less likely to get their A1C monitored. So these things make for worse outcomes. HPAC housing, there was a very large study that talked about this. Supportive housing really helped people with diabetes, particularly type 1, helped them stay out of the emergency department and got them to see primary care doctors. Here's a list of common health issues. There's a lot of infectious illnesses, mental health disorders, chronic illnesses like diabetes that we're talking about today. A lot of unhoused people have wounds, or they even have diabetic foot ulcers or diabetic ulcers in general. These are pretty severe in the homeless population. Every time you go out, you'll see somebody with feet that look like this or diabetic ulcers. Okay, so does anybody have any questions about diabetes before we move on to our last topic of the day? Okay. Transtheoretical model of change. So this is something that we try to teach everybody before they go out into the field in person. So it's kind of like a model for helping people change their behavior without being confrontational. So, studies, a lot of psychological studies have shown that if you just tell somebody like, hey, you need to change, they're not going to change. And today we're going to be applying this to type 1 or sorry, to diabetes, but it's really used more in 12-step programs. It's used for people that need to manage their weight. It's used for smoking cessation, for gambling, for people with anger issues, for people who are performing badly in school. It's used for everything, but we're going to apply it to certain things. Just today for the examples we're going to do in a minute. So there's different stages, and it's an upward spiral, we call it. We're spiraling upwards. So people go through like pre-contemplation. They don't know, like they don't recognize they have a problem. Contemplation is they are aware of it, but they're not doing anything to change it. And you continue spiraling upwards, slowly working towards making action and fixing your problem or changing your behavior, and then relapse and going back to pre-contemplation. And you can jump from place to place in the wheel, and it's not static, it's a circle, and it's okay to fall back and make mistakes. So the key line of the trans-theoretical model of change, or more colloquially, stages of change model, is you can support change, but you can never suggest change. So if you're going to talk to somebody who has a drinking problem, like they ended up homeless because they get drunk and then they yell at their wife or they do badly at work, we never say you have to stop drinking, or hey, I think you should go to this treatment program here, let's get you to do it. And they're not ready to talk about change, that's not going to be helpful. In fact, that's going to make them withdraw more. We want to support them at each step of the way, so that way they feel empowered to change rather than being told you have to change. So again, it's in a circular model. You can exit and re-enter at any stage. So I tried to make it a little bit funny with memes, but I'm not sure how they're going to hit. Pre-contemplation. So in this stage, they don't know that they have a problem. They're unaware of it. Like this person might be drinking a lot. They might be yelling at their boss, and they have no idea that this is a problem for them, and they're blissfully unaware, even though they're feeling negative impacts of it. Like they might have lost their job, or they're getting fatty liver disease, or their eyes are turning yellow because they're drinking too much, or they, yeah, it's they are unaware of the problem, but they have one. And in this stage, if you recognize that the person is in the pre-contemplation stage, it's best to provide non-judgmental information and personalized feedback to raise awareness of why change might matter to them. As you can see, the person on the right has a lot he needs to change. Contemplation. So contemplation is like you recognize that you have a problem, but you're not ready to do anything about it. You're like, yeah, I have a problem with drinking, but I'm not gonna go and I don't want to go to rehab. That's not on the table. Or yeah, my blood sugar runs pretty high, but it's okay. I don't need to deal with that. Preparation. So this is a very hard part of the process. They recognize that they have a problem, but somebody type something in the chat. Oh, LMAO. Okay. They recognize they have a problem, but they're not ready to work on it. Or sorry, they recognize they have a problem, but they're ready to work on it. They're getting stuff in line. So they might be registering with a rehab, going to an anger management, trying to figure out a way to go to an anger management class. They maybe haven't gone to their first one, but maybe they made their appointment or they figured out one that they want to go to. They might have an eating disorder and they don't want to eat, so they figured out, hey, maybe I'm gonna reach out to a place that offers services, or I can't take care of myself. I'll call this hotline that can maybe get me a support with somebody who can come and take care of me. You notice they're in the preparation stage, collaborate on a concrete, manageable plan, setting a specific first step and a timeline to boost their confidence. Yeah, thought the cat was pretty good description of this. It's a very hard stage. I'm not sure. Do not sure if I quite went over the last part of contemplation. So the key to supporting somebody who is in the contemplation stage is encourage them to weigh the pros and cons of changing by exploring ambivalence in conversation. And that touches on motivational interviewing, which we'll talk about in another lecture. But basically, like you aren't saying like, yeah, I think you should do this. I think this is the right option. Like maybe you have a friend that needs to go to a rehab facility and you're saying like, yeah, I think you have to do that. It's better to say, it looks like the rehab facility is really be great for you. You have a lot of benefits, but on the other hand, you're unsure of it. And I know a lot of people are like, hey, like this person really needs to go to the rehab. It's the right thing for them. But you can kind of, when you weigh the options to explore their ambivalence, it's the right strategy that I found working at the suicide hotline is to kind of say like to give a lot of pros as to why they should do it, and the cons of doing it should be their feelings. So you're not saying like, yeah, you should go to rehab, but it'll be expensive. No, that's not a very good thing to say. Like maybe their chief worry about going to your rehab is financial responsibility. You could say, yeah, like I know you want to go to rehab because that will be really good for your physical health. You'll gain like some agency back. Your health will get in check. Your relationships might be better. There's so many good things. But on the other hand, you're feeling worried about financial responsibility. And it's also good when you're weighing these pros and cons is to offer support for the cons, like offer emotional support, offer logistical support. We're not trying to weigh the pros and cons saying, yeah, there's bad things about getting help. No, you're talking about their feelings. If there are bad things about getting help, talking about the feelings around those bad things like finances, or they might have to leave their family for a little while, or it'll be hard. It's really reflecting the feelings when you're talking about cons. Action. So this is the biggest phase. You're making change. This is you're actively going out there and doing something. So you're going to a rehab, you're talking to your endocrinologist, you're going to a place that offers shelter for homeless people, you're getting signed up for healthcare. This stage feels the best, it's easiest to maintain, and partially because you're getting so much praise from people around you. Everybody's like, yeah, like you're doing all of this change and it's been so hard. We're so proud of you. And it feels really good. And during this phase, you should be praising them for their effort, help them troubleshoot obstacles like you have been the whole time, and help support them in their journey. Like if they want somebody to do their 12-step rituals with, you should do that with them. Your the unhoused person really wants like support not buying alcohol and they want to talk to somebody at our hotline for a few hours, just be on the phone with them for a couple hours. The homeless hotline. We're trying to help them. Um, the memes are getting progressively more unhinged. Um, so maintenance is the hardest phase. Maintenance, you're kind of having to maintain everything that you worked for, except you're not getting all of those like accolades from everybody around you. There's no more praise, there's no more good jobs. Like it's just you're having to chug through it and you're having to deal with the temptation every day, and you're not getting all the rewards of the new action, the actions that you took. And during this phase, it's important to remember to still celebrate all of their milestones. Let's say like a homeless person is calling into our hotline regularly. We keep notes on all of the unhoused people there. So you should look back at the notes and realize, yeah, this person made a big change recently. We should, acknowledge that every time we talk to them or every other time we talk to them so that they know they're doing a good job. Or let's say an unhoused person is dealing with their diabetes and they had really high sugars for a long time and now they're more under control, or maybe a little step like, yeah, they're checking their sugar now. We really want to say, yeah, you're doing a good job. Even if they haven't made a lot of change in a while, we want to support them and be happy for them because they did make a good change. And we want them to maintain that before they fall into to relapse. And relapse is an expected and normal and okay part of changing. Everybody makes mistakes. Everybody slips back, and putting shame on that isn't going to help anybody. Let's say an unhoused person worked really, really hard to get their sugars under control, and then they drop they drop the ball and they're all over the place. We're not going to say, "Hey, you were doing so well. What happened?" No, we're gonna meet them where they're at. If they don't want to change, they don't want to change. We might offer them support, like, hey, like I'm here to help you in any way that I can. And how are you feeling about this? We're just not here to shame them and tell them they have to change. We're kind of going back all the way to step one of pre-contemplation. We want to use those skills wherever they're at. We use those type of we meet them where they're at. So it's good to normalize the setbacks, review what they've learned, help them recommit to their plan of change. Okay, so now we're gonna have a little quiz for like the comprehension for this thing. So, what stage of change is this? David is living in a shelter and says, yeah, I know I have diabetes, but honestly, I don't think I need to worry about it right now. I've got bigger problems than my blood sugar. Is he in preparation, relapse, or pre-contemplation? You guys can put it in the chat. Yeah, nice. A lot of you said pre-contemplation, and that's right. He doesn't see that it's an immediate concern. He's not super aware of it right now. He's more focused on just surviving on the streets, and that's okay. We're not gonna say, "Hey, you have to change these ways." We're gonna acknowledge like he has other things that are at the top of his mind, like maybe David is worried about being robbed or beaten because he's on the streets. He's worried he doesn't have a roof over his head. He's worried about so many things. And that's a good analogy for other people, in our own lives. Like if other people are like we're going up to somebody and saying, "Hey, you have to change this behavior," they're going to feel you're kind of missing everything that's behind that. Like maybe the person is struggling with their own internal problems or circumstances that you don't see. Like no matter how close you are to somebody, you don't see everything. So it's important not to go at somebody and tell them they have to change. We want to treat it like, you're going through a hard time and I'm going to support you through change, but I'm not going to make you change because that has to come from you. It can't come from me. How do you best support Angela? So Angela says, I want to start checking my blood sugar, but I don't have a kit or know how to use one. I'm tired of feeling dizzy all the time. So, what do you guys think is best? Like A, the one on the left, offer to help her get a glucose meter and teach her how to use it. B, remind her that if she doesn't take care of herself, things will get worse. C, tell her she should wait until she has stable housing before trying. Yeah, we should offer to help her. Oh, I don't know why it's at preparation stage. Yeah. Oh, yeah. Angela's in the preparation stage. She wants to act, but she needs support. So, helping her get a glucometer, talking about this is a great way to help somebody in the preparation stage. Then our last question, how would you support Marcus? Marcus lives in a tent and was recently given a glucometer. He tells you, I've been checking my blood sugar and it's always high. Even when I don't eat much, I don't think anything I do makes a difference. So A, I want you to know it is very dangerous to have high sugar, and I care about you and worry you might have more health problems. B, I think you should try giving yourself more insulin. Those numbers are really high. Or C, sounds like you're frustrated. Can we talk about what you've been eating and what you've tried so far? Yeah, so it seems like he's in the contemplation stage, but he has like low self-efficacy. He's having a hard time kind of getting out of it. So acknowledging his frustration while helping him reflect on what he's doing builds trust and gently guides him towards taking ownership again. So that's it for our presentation today. Thank you all for coming. Um, wow, there were so many of you. I'm glad that everybody came. Yeah, does anybody have any questions? No, well, thank you all for coming. If you guys have any interest in doing more research than you guys are already doing, you can go onto the website and read about it. We're looking for more people. So, yeah. Thank you, everyone. Bye.
Thank you.
I just want to say while I have everyone still here, I also just wanted to reach out and say thank you to everyone. And just overall, if there are any questions, do feel free to send them and we can get back to you if you're interested in the study or more research information as well. But
Any,
besides from that, I wish everyone a great weekend.
I have a quick question about the sexual assault study. I just started like doing the data extractions for it in particular.
Sure.
I wanted to just know, like, I've seen like a lot of people already on it. Is it like too late to like be joining that now and or like it's because I know we have to do 25 and if it's like, 5 extractions minimum per week, that would be about 5 weeks of like work to like receive credit in the study and like minimum 5 weeks of work.
um, Yeah, and Ray, like you can always give this answer to other people who ask it too, but no, you can. We're going to be really, really lenient on that. Anybody who contributes to the study will get credit on it, pretty much. Like
Oh, okay.
if you do 5 extractions and you're proving that you actually do like the extractions every week,
Yeah.
when you start and you text people back, then it's totally fine. If you join at like the very last week and there's like 2 weeks left. Speaking of 2 weeks left, there are only 2 weeks left in that study.
Oh, okay.
So,
Yeah.
we got a lot of new data, and it looks like we're going to be doing 2 more weeks of extraction. We're wanting everybody to do at least 5 data extractions, hopefully
Mhm.
more. And then, yeah, that's we're getting really close to publishing the
I
paper.
I wanted to jump in as well. Something because I'm not sure exactly how many days you've been on board on my team. But there have been a couple people who just joined like a couple days ago. So I told them also like the Sunday deadline for this week, like it'll be easy. I just want everyone to prioritize finishing the modules. I think having a full grasp of the information will be best because then you're able to do it with confidence. So as long as your trainings are done, like feel free to take a crack at it, but there's no
Yeah.
pressure to get 5 done in the next like 2 days.
Yeah,
Yeah,
I
so don't
already I
worry about
already
it. Do what you
finished
can,
the
and then we can review it.
I finished the modules, so I've just begun already doing those data extractions already and trying to, you know, contribute.
Thank you, Mac. Yeah, I saw what you did, and you did so
Yeah, of
much
course,
work.
of
That's
course. I'm sure
exactly.
you're doing a great job.
Do I
Yeah.
need to like email
Thank
them
you.
like
Yeah.
after they're completed I did already share the doc, but I don't need to like be like, oh, I finished this week. So like you guys will just check on those.
I think it's good. Like,
Okay, cool.
we'll
Cool.
just take yeah, we're basically done with the study at this
All right.
point. We're just doing writing the paper now.
Oh,
So
okay.
yeah, anybody who's on this chat, please feel free to come and we'll do some more meetings about writing the manuscript. We'd love to have you. And everybody who comes to those meetings will get credit on the paper. we're really happy. I do have to get going pretty soon, but yes, Angie?
Hi, yeah, I just have a similar question about the sexual assault study paper. I saw that there are like two more slots left. I was wondering if I can take that just because I do want to do a little more research, and it's just, I, kind of like want this experience, if that's okay.
Yeah, you can talk to Ray about that. She's in charge.
Okay, yeah, sure.
Yeah, that'd totally be fine. You have my number, right? Feel
Yes.
free to send me a text. I'm actually in LA with family right now.
Oh,
So I'm away from my laptop, but I can also like we can send an email to the Valiant like Foundation email, and then that way we can add you to the document. And then from there, are you currently in the text group chat? You are, right?
yeah. Yeah,
Okay.
I also like I'm on a document right now. I saw that there was like two more slots, and I was wondering if I can, just fill them up.
Yeah, I
Yeah.
don't know what the
Yeah,
slots mean, but do
that's
whatever you want.
Yeah, thank you so much. I just want to make sure if, if it was okay before, I don't
no,
know.
of course, of course. You're good. You're totally good. And I'm really grateful to have you on board. So welcome.
Yeah, thank you so much. Yeah, but I'll text you further more on iMessage.
Okay, sounds great. Sounds great. I
Good.
look forward to hearing from you guys.
Thank you.
All right, have a good night, everyone. Take care.
All right, good
Hi,
night.
Ray. Yeah, I'll see you guys later.
All right, bye.